Hello, my name is Dr. Carla Moreira. I am a practicing vascular surgeon in Providence, Rhode Island. My preferred pronouns are she, her, and hers. It is a great pleasure and an honor to be a part of this panel, and I would like to thank the VAM Educational Committee for this opportunity. I have nothing to disclose. In preparing this talk, I had a chance to review the objectives set forth by the program organizers. I believe that incorporating cultural competency principles and training at all levels of vascular surgery is an essential step to meeting these goals, developing tools and strategies to increase diversity, equity, and inclusion, providing us with better tools to evaluate, mitigate, and in some cases call out the harmful role that race, ethnicity, gender, and social determinants of health play in the care and outcomes of vascular patients. And lastly, support upstandard behavior, which promotes clinical and educational environments that are free of harassment and harm for all. So before getting too far ahead of ourselves, what is cultural competency? There have been many definitions that have evolved throughout the years since this term came into our collective consciousness in the late 80s, early 90s. Currently, cultural competency in the clinical setting is generally defined as a provider or a healthcare system that provides care which is tailored to meet the patient's social, cultural, and linguistic needs. Through the evolution of cultural competency curriculum, there has been a major paradigm shift away from the traditional way that some of us might think of cultural competency, which was an external pursuit of knowledge and skills about specific cultural groups that was, I believe, fairly criticized because of the potential harm associated with this approach of creating checklist of characteristics about patients that or people that are different than yourself, and also stereotyping. Currently, the way to understand, or the framework to understand what cultural competency is that it's a continuum of internal professional development, which includes critical self-reflection of one's values, beliefs, privileges, and biases. This continuum and being on this continuum will allow for the development of an authentic desire to understand, respect the social and cultural backgrounds of the diverse individual and patients that we will interact with in our practice. This will hopefully culminate in obtaining the knowledge, but also more importantly, the will to act, to look and support policies that identify and address health disparities as a necessary element of running a culturally competent vascular practice. As individual vascular surgeons and really the entire vascular workforce, we need to move from a place of cultural destructiveness, which has been shown to harm our patients, harm our trainees, and in some cases, our colleagues, and ultimately obtain cultural proficiency to work and to build systems and organizations that will hold culture in high esteem and use it as a foundation to all endeavors thereafter. Therefore, I want to emphasize that the goal is at the individual level, but also in institutional level, to cement this idea that this cultural competency is a continuum, is a process of potentially lifelong learning and unlearning. We need to be mindful to avoid strategies that apply group-based or one-size-fits-all solution, because these are doomed to fail in an increasingly multicultural society. Rather, the goal should be in understanding and incorporating the key principles of cultural competency and institutionalizing those ideas in this process. So one of the key principles of cultural competency is that diversity is valued. The necessity to increase the diversity of the workforce, therefore, becomes a priority at all levels, but especially at the higher leadership level. This needs to be visible, and there needs to be accountability for when we fall short. In addition, we need to develop the capacity for critical self-assessment and be conscious that there is always inherent power dynamics that exist when different cultures interact. Once we have the knowledge, then we need to go one step further. We need to act and practice and put into daily use the principles of cultural competency to develop, as I mentioned, the policies and the methods of service delivery that we reflect our values and the esteem with which we hold a cultural competency. As already mentioned, there is no place for checklist or one-size-fits-all approach. There are many validated instruments, countless resource materials available. There are professional services available to aid you and your institution in this journey. The implementation and evaluation of such curriculum and initiatives needs to take into account the specific needs of your patient population, your workforce, and the institutional capacity. And I believe is beyond the scope of this talk, and therefore I will not specifically touch on these various steps on how to obtain cultural competency, but rather emphasize the importance of getting to that point. So why is cultural competency important for vascular care? We should care about it because through this process, we can recognize, mitigate, and prevent disparities from occurring. And we can use it as a strategy for achieving health equity. As vascular surgeon, this is how we will provide comprehensive vascular care, by helping our patients obtain the highest level of health independently of their race, ethnicity, origin, color, gender, socioeconomic status, age, sexual identity, or expression. Often the term cultural competency had been applied or when referring to racial and ethnic minority population. This is a very narrow application that omits the intersectionality that exists and also erases other marginalized groups who might, although be ethnically and racially similar to their providers, nonetheless are at risk for stigmatization and or discrimination. Yes, racial and ethnic minorities, individuals with disability, and members of the LGBTQ plus communities are the groups most commonly who experience health disparities in the US healthcare system. However, these groups are not mutually exclusive, and the diversity within each group is often simplified, oversimplified, or not fully captured. But the data is quite clear. Minorities are more likely to lack health insurance and are disproportionately covered by public programs, which like Medicaid, which reports of insurance-based discrimination are greater. Compounding this effect occurs in patients who have reported insurance-based discrimination, often tend to report delay in care and substandard care received. Repeated discrimination is itself a source of chronic stress, which has been shown to result in damage to the immune system, the development of cardiovascular disease, and mental disorders. These are all things that makes it harder for us to provide good, equitable care to our patients. racial and ethnic minorities have continued to experience greater rates of disease, disability, and death. And compared to their white or non-minority groups, this is even when controlling for access-related factors. The problem of underrepresentation of certain minorities and women in surgical specialties is one that is also concerning. Lack of diversity in vascular care is especially problematic because minority patients tend to prefer physicians who share their backgrounds and have improved outcomes when treated by minority physicians. We also have seen no significant change in the matriculation and application of self-identified URMs in surgical specialties. This was a study recently published in JAMA. There was a slight increase in the proportion of URMs applying and matriculating in vascular surgery, and this is a glimmer of hope and good news. However, the lack again of diversity within the vascular faculty and leadership rank should continue to be a concern. Cultural competency then with inclusive of the design, cross-cultural curriculum, provider emphasis on cultural humility and training on social justice paradigm, I argue is critical to our development as professionals. This is a necessity for us to evolve and continue to be dynamic, forward-looking, and culturally proficient organization that will meet the challenges of the future. In some ways, I feel that this talk is like preaching to the choir. The fact that you are here, you are listening or viewing this talk tells me that you are interested. My message is for those who are not here. If you understand the breadth and the depth of the issues facing vascular surgery, our entire healthcare system today, you know that we are in trouble. We are needing to provide a way to integrate cultural competency training at all aspects of vascular surgical training is no longer a matter of want, but rather a necessity if we are to meet these challenges, as I mentioned before. So let us not let these opportunities pass us by. Let's commit to becoming culturally proficient. The continuum is of intentional, multi-level daily work. So where do we start? Where do we go from here? The following are steps that each one of us can take as individual vascular surgeons, program directors, department chair, and organizations. We can start today, and some of these require minimal effort or resources. Intentional diversification of our workforce in leadership is key. The presence of diversity within medicine has been shown to increase the cultural competency of all healthcare providers. Become a champion for promoting diversity and inclusion as an institutional priority. Prioritize effort at increasing the numbers of URM students, trainees, and faculty within vascular surgery. Both of these have been shown to be good strategies to eliminate health disparities, promote social justice, and meet the needs, again, of our changing patient population. Participate or create a URM student recruitment event and mandate that there are longitudinal curricula for all members of your organization on structural racism and implicit bias. Once you recruited a URM student, trainee, or faculty, you must commit to support them, to retain them, and to promote them. Create an environment that is welcoming and inclusive by promoting anti-racist actions or behavior on a day-to-day basis. create DI counsel to address incidents of bias that may arise, provide emotional cultural support through mentoring, coaching, and sponsoring, perform outreach to minority communities, so that you may better understand their needs. Lastly, I want to close with words of encouragement and optimism for the future. I have faith and I have seen the fruits of the labors of many of you in this panel and in the audience. Let's continue this work. Let's break the apathy of inaction. Let's push ourselves, our institutions, and the society to take the bold steps forward. Let's inextricably bind benchmarks professional development with immeasurable quality indicators and quality outcomes for all current and future vascular surgeons. Let's operationalize the tenets of cultural competency and professionalism into the daily workforce of all aspects of vascular training, as well as the maintenance of certification. Let's prioritize inclusion and equity to significantly improve the recruitment, training, and retention of a diverse vascular workforce and leadership. Let's ensure that we speak clearly and have transparency in all phases of the recruitment, selection, and promotion process to ensure equity and inclusion. We can do this. We are vascular surgeons. I have faith and I know we got this. Thank you.